Hello, everyone, and good afternoon, Dr. Perry. So it's good morning for you. So today we have Dr. Ari Perry from UCSF. He is live from San Francisco. So he is going to give us a presentation on approach to gliomas. First of all, thank you, Dr. Perry, for sparing your time with us. And Dr. Perry needs no introduction, but still, I would just like to have a few words. So Dr. Ari Perry, he is the professor of neuropathology at UCSF. So he is a very well-known neuropathologist. So he has lots of publications to his name, and he is author of a major neuropathology textbook, and he is also the editor of the WHO classification, that's the WHO Blue Book. And more importantly, Dr. Perry is often known and he is popular as the singing neuropathologist. So it's all yours, Dr. Perry. Thank you so much.
Thank you, Rifat, and I apologize for the delay this morning. We had internet issues at UCSF, but it's a pleasure to be with you, and I'm grateful to Rifat for organizing this and for getting me into the 21st century. This is definitely the first time I've used Skype, much less given a lecture with Skype, but hopefully everything will go well. So I'm going to talk about the approach to gliomas today. Now my screen is, so it seems like everything that can go wrong has gone wrong. Now my screen seems to be stuck. Give me a second. Okay. Let me see if this works now. No. Okay. I'm going to have to end this for a second and restart it. All right, we're back. Sorry about that. So starting off with just some background. So CNS tumors are certainly not the most common things we see, but it accounts for about 100,000 new cases every year in the United States. And unfortunately, it has now become the most common cause of cancer deaths in kids, not because the incidence has gone up, but because what used to be the most common leukemias and lymphomas has gotten better therapies. So unfortunately, we've bumped them for this distinction. Certainly in adults, actually metastases to the brain are more common than primary tumors, though we deal with many of both. If you have to just remember a few tumors in both adults and kids, just remember 3 in each category. So most of the adult tumors, about 2/3, occur in the supratentorial space, so above this structure here in this anatomic chart. And the most common things are diffuse gliomas, which is what we're going to talk about, especially glioblastoma, metastases, and meningiomas. And in kids, the opposite is true. So about 2/3 of them are below the tentorium, and they are especially medulloblastoma, pilocytic astrocytoma, and ependymoma. And we'll talk a little bit about pilocytic astrocytoma, but not about the others. So I often tell our own residents that neuropathology is a lot like real estate, and location is almost everything. But in addition to that, when you're trying to whittle down the differential diagnosis, it's too hard to think of the over 120 entities in the WHO without narrowing it down. So patient age is critical because the tumors we see in kids are quite a bit different than in adults. And neuroimaging is also critical because that's often become our gross pathology surrogate. So location and imaging features are critical in terms of differential diagnosis. So today we'll talk about the gliomas in specific. And if you think about it, there are 3 types of glial cells normally in the brain: astrocytes, oligodendrocytes, and ependymal cells. And those are also the major categories of gliomas. So the astrocytomas and oligodendrogliomas, most of them grow in this diffuse pattern, which we'll talk about. And so if you hear the term diffuse glioma, that usually means either of those two things, and ependymomas tend to grow in a very discrete, circumscribed pattern, so it's quite a different biology. One of the other things to keep in mind is that in the early part of the 20th century, I think pathologists spent most of their time talking about differentiation. And so grading at that time meant how much do these cells resemble the normal counterparts. And the more they resembled them, the lower the grade. The more they didn't resemble them, the higher the grade. Nowadays, of course, our clinical colleagues are much more interested in trying to predict biologic behavior. And so the WHO, I think, has moved more in that direction. And I should obviously update this to the 2016 version, but the same concept is true. Basically, grade 1 is a benign tumor that nevertheless in a poor location may cause significant morbidity and mortality. But these are benign, potentially curable tumors. Grade 2s are low-grade malignancies. And in the WHO, anytime you hear the term anaplastic, it's grade 3. And these are moderately differentiated malignancies, whereas grade 4 are the highest grade malignancies, such as glioblastoma. So in talking about the gliomas, if you think about it, they only account for about 1/4 of all the tumors that we see. But if you specifically look at malignant brain tumors, then all of a sudden they make up about 80% of the tumors that we see. So this is one of the most common daily issues and problems that we deal with. And unfortunately, glioblastoma is the most common of them. So roughly speaking, if you start with the astrocytomas, you can divide them into the larger group, which are the ones that grow in a diffuse fashion, makes up about 3/4 of the cases, and the fibrillary astrocytoma is sort of the prototype, whereas the ones that tend to be more favorable and circumscribed are about 1/4 of the cases, and the pilocytic astrocytoma is the prototype of that one. Now, another concept to keep in mind is that these things are named because of the cell type they most resemble, not because we know the lineage of these tumors. So it's with astrocytomas, they most resemble the normal or reactive astrocytes like you see here. This is tumor on the right, reactive on the left. That does not mean that an astrocytoma from a mature astrocyte. In fact, it's from some sort of progenitor cell that may lead to a variety of different glial neoplasms. But this is the way they're named. In grading the astrocytomas, there's a very simple way to remember that, and this has been around for at least a couple of decades, and I call this the AMEN acronym, and that is atypia, mitoses, endothelial proliferation, and necrosis. So if all you have is the atypia, that is a grade 2 tumor. Now, why does it start at grade 2? All of the diffuse gliomas are malignant by definition. So if you only have atypia, that's a grade 2. If you add mitotic activity, that's a grade 3, and we always use anaplastic with our grade 3, so that's an anaplastic astrocytoma. If instead now you add endothelial proliferation, also called microvascular proliferation or endothelial hyperplasia, or necrosis, then that becomes a grade 4, which is synonymous with glioblastoma. So that's an easy way to remember the grading, though as you'll see a little bit later when we talk about molecular biomarkers, there are some problems with our traditional grading criteria. So starting off with the lowest grade diffuse glioma, the grade 2, here I've put for now the IDH mutant subtype because this is the most common subtype, though we'll talk about what that is a little bit later in the talk. So this can occur at any age, but the peak is in the 30s, so these are young to middle-aged patients. And they tend to be slow-growing tumors with insidious onset. On imaging, they are non-enhancing tumors, and this is critically important because that gives us some sense about sampling adequacy on a biopsy. So in other words, if we have a contrast-enhancing tumor and it looks like a low-grade astrocytoma, that is almost certainly an undersampled higher-grade glioma. So it's always important to look at the imaging as well. Now the problem with these is that they eventually will progress to higher-grade tumors, and there's quite a bit of variability, but overall the survival is about 5 to 10 years. Probably more than that if you look at the IDH mutant subtype. Now, these are called diffuse gliomas because by the time they're diagnosed, there often is widespread dissemination throughout the brain. So if you look at the imaging, which is again our gross pathology in a way, typically on T1 weighted imaging, like what you see on the left with contrast, you see this ill-defined, low-density lesion, and it's hard to tell where this tumor starts and where it stops. Now we can tell there's mass effect because the ventricle is compressed and the sulci are obliterated, as you see on this side. So there is a mass here, but it's ill-defined. And often if you were to take biopsies many centimeters away from this mass, you would still find tumor cells there. Often the easiest way to see this is with either T2 or a modified T2, in this case FLAIR image as you see on the right. And you might say, well, again, here, maybe this is the margin of this tumor, but if I were to take biopsies, even on the other side of the tumor, often we'd find tumor cells. So to some extent, the horse is out of the barn door by the time we've diagnosed these tumors. Morphologically, what we're looking for is cytologic atypia. And so the red arrows here, I've shown reactive astrocytes in comparison to fibrillary astrocytoma cells with the black arrows. So you'll see they're slightly enlarged, they're more irregular nuclei, they're hyperchromatic, meaning they're darker than normal. And they often are described as naked nuclei because the cytoplasm is hard to discern from the adjacent fibrillar background. So these are the fibrillary astrocytoma cells, and this is a grade 2 astrocytoma. One of the maybe nice or not so nice things about the diffuse gliomas compared to other areas of surgical pathology is, of course, we don't have to deal with inked margins like we do with cancers in many other locations. And I actually borrowed this slide from an ENT pathologist, but I think it works just as well in neuropathology. So if the surgeon wanted to do a curative operation, obviously they'd have to do something that is just not acceptable. And so we don't deal with inked margins, although occasionally we will get specimens that are labeled as margins by the neurosurgeon. And what they basically want to know is this cellular tumor? Have I gotten around the main part of the tumor? Or just a few atypical cells here and there, which is not worth chasing after. So just to drive home the point, this was actually from an autopsy case in a patient that had a grade 2 astrocytoma of the frontal lobe. And this is actually a specimen from the pons. And so you can see many, many centimeters away from the main mass, we're seeing there continue to be individual tumor cells that are infiltrating the brain, as you see here. And this is the reason why these are not surgically curable tumors. Now, one of the other interesting patterns that we see with diffuse gliomas in general is that they often form what are called secondary structures. And this is probably the paths of least resistance in terms of spreading. So you can see more cellular tumor under the pia, or what's called subpial condensation around blood vessels and around neurons, what we call perineuronal satellocytosis. This was first observed by Dr. Scherer in 1940, and so these are often called secondary structures of Scherer. And the point of this is that almost nothing else besides diffuse gliomas will form these secondary structures. So when we see this as pathologists, this is the first thing you think of. This almost has to be a diffuse glioma when you see these patterns. The grade 3 or anaplastic astrocytomas typically occur about a decade later. They're somewhat more aggressive and therefore more rapid onset and more rapid progression. And the average survival now goes down to about 2 to 5 years. Although again, it's probably much higher than that if you're specifically considering the IDH mutant subtype. And here the main feature that we're looking at is mitotic activity, though kind of subconsciously, a lot of what we see as well is increased cellularity. So this is not, cellularity is not part of the official grading, although it often goes along with the higher grade. I also put one of the variants here on the right because often this variant presents as a grade 3 tumor, though it doesn't have to be. It's acidic subtype in which we have this eccentric belly of pink cytoplasm. So gemistos in Greek means full or stuffed, and you can see these astrocytes are basically stuffed with the GFAP filament that gives us this pink eccentric cytoplasm appearance on H&E. Now, unfortunately, as I mentioned earlier, by far the most common of these is the glioblastoma, which is also the most malignant and most aggressive. And here again, the peak in age is about a decade later. There's much more rapid onset and progression. And the most typical appearance that we see on imaging is a rim or ring pattern of enhancement, which I'll show you in a little while. And still, despite many decades of research and clinical trials, the average survival is only about a year for the more common IDH wild type form, which is about 90% of the, and maybe 2 to 3 years in the IDH mutant cases, which is only about 10%. So here's the typical appearance. And you see with this correlation with an autopsy case, basically the center often looks on T1 weighted post-contrast images, gives you this low density appearance. This is where all the necrosis is and has this yellowish appearance on gross. The ring enhancement is where the microvascular proliferation typically is. And because those blood vessels are abnormal and don't have the normal tight junctions between the endothelial cells, when you give someone intravenous material, it spills out in those areas, and that's what gives us this ring pattern of enhancement. This area of low density outside the ring is what radiologists often refer to as the edema, although typically we also have infiltrative tumor in those areas as well. So what we look for histologically is microvascular proliferation. And often people will focus on the fact that these abnormal vessels are glomeruloid, meaning they have multiple lumens, as you see here. In my opinion, the more important feature is that they're multi-layered and that the endothelia are thick and prominent. So that's often what I look for, and it doesn't necessarily have to be multi-layered, as you see there. The necrosis that we often see is often associated with palisading of tumor cells at the edge of the necrosis. So tumor cells line up necrosis, and people are still arguing about whether these cells are running towards the hypoxic center or away from the hypoxic center, though it doesn't really matter. This is a very distinctive pattern. It's often serpiginous, as you see here. It's a little bit analogous to the seeds you see in a cut section of a kiwi. So when we see this pattern, it's very typical of glioblastoma, not pathognomonic, because we can see it occasionally in other tumor types, but most commonly in glioblastomas. Now I'll show you a few of the variants of glioblastoma and patterns of glioblastoma. In the old WHO schemes, now going back at least 2 or 3 WHO blue books, we still had the multiforme in the name. And this is really, I kind of like that because it highlights the fact that there's multiple histologic patterns that we can see, and we've talked about some of these already. A couple of new ones in the latest WHO is a pattern called GBM with primitive neuronal foci, which I'll show, and a variant called epithelioid, which I'll show. So just very quickly, there is a giant cell variant of glioblastoma that occasionally occurs in a somewhat younger age group, sometimes more superficially, and may even be attached to the dura, such that meningioma, oddly enough, becomes part of the differential diagnosis clinically and radiologically. Histologically, these are characterized by these very large, bizarre, often multinucleated giant cells. And the old name for this is monstrocellular glioblastoma because these are such huge, bizarre-looking cells. Typically, they're GFAP positive, as with most other glial neoplasms. And this is maybe about 2% of the glioblastomas that we see. The behavior and treatment is basically like any other glioblastoma, although there may be a somewhat higher risk of dissemination or metastases with the sarcomatous component of gliosarcoma, with giant cell GBM, which is analogous to gliosarcoma. Gliosarcoma can also be somewhat more superficial, attached to the dura, and occasionally mistaken for a diagnosis of meningioma. This is another one that's about 2% of the subtypes that we see. They tend to be somewhat more solid in terms of the interface with adjacent brain, though you see this kind of feathery, ill-defined edge, and there's always some invasion into adjacent tissue as well. So the way you think of gliosarcoma is this is thought to be a type of mesenchymal metaplasia within an otherwise glial neoplasm. And so it's analogous in many ways to carcinosarcoma in other parts of the body, where you have this mesenchymal transformation. So here you see the cellular glioma portion here, kind of interweaving with a more solid spindle-celled fascicular sarcomatous component here, although clonally it came from derived from the same clone. So typically the sarcomatous component is reticulin rich, and here's a whole mount of this tumor where you can see the sarcoma component is reticulin rich, and you have the opposite pattern with GFAP. The glial part is GFAP positive, and the sarcomatous part is GFAP negative. Now these tumors, most often the sarcomatous component will resemble fibrosarcoma, but they can look like leiomyosarcoma and be positive for myogenic markers like SMA, as you see on the left. They're often, although this isn't specific, they're often positive for CD34, as you see on the right. Though they can be a lot of different things. I've seen osteosarcoma, chondrosarcoma, liposarcoma in rare circumstances. So any type of sarcoma that you can think of can occur in gliosarcomas. A much rarer type of metaplasia that can be seen either in GBM or gliosarcoma is an epithelial type. If it just looks epithelial, we often call it adenoid. But if it's true epithelial metaplasia, this can occur in very rare circumstances, and you can have squamous morioles and cytokeratin positivity that can occasionally cause confusion with metastases, as you see in this case, even CK7 positive in this particular example. Another very rare subtype that we occasionally see is the granular cell astrocytoma. And anytime in pathology we say granular, that means it's full of lysosomes. And so this is basically a tumor that's stuffed full of lysosomes, and that can make it look, in some cases, remarkably similar to macrophages. Although the tumor cells typically are somewhat larger and more atypical, as you see here. But a number of these cases will raise the differential with demyelinating disease or infarcts and things like that. And they can, in some cases, be deceptively bland. In other cases, the lysosomes are very eosinophilic and more like what you think of with granular cell tumors in other parts of the body. If you look in between these granular cells, you can see these more typical fibrillary astrocytoma cells. And on imaging, these often will look like high-grade gliomas. So this is a variant that can appear as any grade, though they typically will behave like glioblastomas. They're always IDH wild type, and they're typically in older patients. So if you think of the diagnosis, you can do GFAP, and these cells will be GFAP positive. They'll be positive for other glial markers like OLIG2 as well. But they can be positive for lysosomal markers like CD68, so just keep that in mind. So typically the macrophages that are always in the background will be more intensely positive and much smaller than these tumor cells. Okay, so a not so uncommon variant that often causes a lot of diagnostic confusion is the small cell variant of glioblastoma. This is always a primary IDH wild type variant of glioblastoma. It's maybe about 10% of the cases that we see, and this is the one type of glioblastoma that is not multiforme. It's actually monoforme, meaning that all the cells look very similar, and they tend to be oval or rounded, and can even have halos and chicken wire vessels and a lot of things that overlap with oligodendroglioma. So here's an example. You can see that on low mag, really mimicking an anaplastic oligodendroglioma. That's often the first thought. At higher mag, there's often this disconnect between the somewhat delicate, chromatin that you see here and the very high mitotic index. So that's often the first clue for me. But some of these can be very similar to oligo, and you may have to do additional markers. So in this initial study, just on morphology and a little bit of genetics, you can try a GFAP, and it may highlight processes that you didn't see on the H&E. They are typically highly proliferative tumors, so the Ki67 is high. And often they have EGFR expression, almost all of them, although this isn't very specific. If you look for the mute type of EGFR, the variant 3, about half the cases will be positive. Percent of the cases will be EGFR amplified, and almost all the cases will have loss of chromosome 10. But as we'll talk about a little bit later, probably the easiest thing to distinguish these is IDH immunohistochemistry and or sequencing. So all of these will be IDH wild type, whereas by definition, all oligodendrogliomas will be IDH. The other confounding factor is that maybe up to 30% of these cases will actually present as non-enhancing or minimally enhancing tumors, and you don't see necrosis or microvascular proliferation on the biopsy or resection. So technically the highest grade you can give it is a grade 3. When we followed these cases, often within a couple of months, these became ring-enhancing masses. And so what we think this is representing is just an early presentation of glioblastoma, where we can't quite call all the features of glioblastoma. A much more recent addition now is this, this rare subtype that often causes a lot of diagnostic confusion with embryonal neoplasms. In the original paper where we described this, we called them peanut-like components, but in the new WHO, there was a desire to get rid of the term peanut, and so these are now known as malignant gliomas with primitive neuronal components. And here's what they look like. So they look like diffuse gliomas, any other diffuse glioma that you would see, almost always an astrocytoma, although in rare cases an oligodendroglioma. And then all of a sudden you see these discrete nodules. It's like a clonal expansion that looks like something else has happened in those areas. They're much more primitive looking. They have some degree of neuronal differentiation. They often lose their glial features. They may even have homerite rosettes, as you see in these examples here. So they can look like medulloblastoma or other types of embryonal neoplasms. And typically there is loss of the glial markers in these areas and gain of neuronal differentiation with synaptophysin or neurofilament or NEUN, as you see here. And these are extremely proliferative, like other embryonal neoplasms in that component that resembles an embryonal tumor. And interestingly, most of them are floridly P53 positive. So looking at the genetics of these, the most common thing they have is a GBM-like alteration, which is loss of chromosome 10, which you can pick up with FISH. But often specifically within the primitive nodule, they may have NMYC or less commonly CMYC gene amplification, which makes some sense because we know that these MYC genes, if you introduce amplification into cell lines, they become very primitive and it basically blocks cell differentiation. So we think this is what's going on. They're gaining some sort of molecular alteration that is essentially blocking the glial differentiation. So clinically and by behavior, these are essentially glioblastomas. The survival, they're older patients. They're not like PNETs or other embryonal tumors in kids. These are mostly in older adults. The survival is essentially identical to glioblastoma in general. This is why this is now considered a pattern within the glioblastoma category. But the one thing that they do a little bit differently is that there's a significantly increased risk of CSF dissemination when we see these primitive components in these glioblastomas. The other new addition to the WHO is this rare variant called epithelioid glioblastoma, or sometimes in the literature it has been called rhabdoid glioblastoma because some of the cells can look rhabdoid. And these tumors look quite different than your average glioblastoma. They're much more discrete looking, as you see here. There's a little invasion at the edge, but there's almost a sharp line around these tumors. They're often superficial in much younger patients, so kids and young adults. And often for me, the first thing that I think about is a metastatic melanoma because cytologically the cells are large, epithelioid to rhabdoid, big nucleoli, as you can see here. Like melanomas, they will of course be S100 positive, but virtually all gliomas are S100 positive. They will be negative for more specific melanocytic markers like HMB45 and melon A. And obviously you look with glial markers, although occasionally you will see remarkably little GFAP positivity, and you may have to use other glial markers like OLIG2 eventually to show that this is in fact a glial neoplasm. Now, a number of these tumors have had lower grade precursor lesions. We have found that by far the most common lower grade type precursor that we see in these is PXA or pleomorphic xanthoastrocytoma, which we'll talk a little bit about at the end. But it shares many features with PXA. And when we see this is most commonly a small component at the periphery of what otherwise looks like epithelioid GBM. So here's an example, same case, the PXA, very GFAP positive with mostly loss of expression in the epithelioid component. Both of these tumors very commonly will have the BRAF V600E mutation, which is different than most other glioblastomas that we see. And we recently wrote a paper about this, highlighting this overlap between anaplastic epithelioid PXA and epithelioid GBM. And virtually everything we found was identical in terms of molecular and immunohistochemical markers. So we still don't have a good way of completely separating out these two tumors. All right, so let's go back to something that again is more common. We see this on a regular basis. And that is the other major type of diffuse glioma, which is the oligodendroglioma. So at least in the vast majority of these cases, which occur in adults, these are now by definition IDH mutant. They have to be IDH mutant and 1p19q co-deleted in order to be called an oligodendroglioma in the new WHO scheme. Otherwise, if you don't do any markers, you can call it oligodendroglioma NOS, but really you should look for these two markers, and it's much more accurate if you've done the molecular type of integration for these, which we'll talk a little more about in a little bit. So these are tumors that, again, mostly involve young to middle-aged adults. Most of them are WHO grade 2. There's only 2 grades that we can have in these, grade 2 or anaplastic oligodendroglioma grade 3. They often have a little bit more corticotropism involving the cortex than astrocytomas, so seizures are a very common type of presentation. These are virtually always involving the cerebral hemispheres. We almost never see these in the cerebellum or brainstem or spinal cord, and it's not clear why that is, because there's obviously many oligodendrocytes in those locations, but that's probably, again, not the precursor cell of oligodendroglioma. So compared to their astrocytic counterparts, these tumors tend to progress more slowly, and probably for that reason, there is a longer survival in these tumors. So maybe 10 to 20 years for the grade 2 category and 5 to 15 years for the grade 3 category. The grade 3 category is defined by microvascular proliferation, high mitotic index, which in one study at least was defined as 6 mitoses per 10 high power fields, and less commonly by necrosis. So here's an example in a surgical specimen, and you can see here's the cortex, follow it out. All of a sudden there's this marked expansion of the cortex and blurring of the gray-white junction. There's involvement of the white matter as well, and this is very common with oligodendroglioma. Now everybody's learned the classic histology is this fried egg or honeycomb-like appearance, where you have this artifact in formalin-fixed tissue with a clear halo around the nucleus of these tumor cells. So this is, in fact, as I said, a formalin fixation artifact, so keep in mind you will not see that on a frozen section. And in rapidly fixed specimens, we often don't see that as well. And so probably more importantly than the halos is this monomorphism with very rounded, uniform-looking nuclei, as you see here. So this is just another example of oligodendroglioma. Here you see the neurons and perineuronal satellitosis, which is just as common in these as it is with astrocytomas. They're often described as having this rich capillary network in the background with this branching of capillaries that often resembles chicken wire, and this here's chicken wire on the right. So this is why we call it chicken wire-like capillaries. And in the old literature, there used to be this notion that oligodendroglioma should be GFAP negative, astrocytomas GFAP positive. Of course, that turned out to be a gross simplification. So if in some cases, certainly only the reactive astrocytes are positive and tumor cells are negative. But in fact, many oligodendrogliomas will have GFAP positive cells. There's mainly 2 types in terms of morphology. One is called mini gemistocytic, of course, because the cells are smaller than their astrocytic gemistocytic counterparts. But more importantly, notice that they still have these uniform rounded nuclei in the background. So the nuclear features is still important. These are mini gemistocytes, small rounded bellies of GFAP positive cytoplasm, or they may look like ordinary oligodendrocytes, and they have this thin rim of GFAP positivity with sometimes with a tadpole-like tail. Those are called gliofibrillary oligodendrocytes, and that can also be seen in oligodendrogliomas. In the higher grade tumors, the cells will get larger, more epithelioid, sometimes plasmacytoma-like or plasma cell-like with eccentric cytoplasm. And we look for these areas of higher mitotic index and microvascular proliferation to make this diagnosis. And here's an example. This is 2 areas of the same case at the same magnification. This is the lower grade precursor, and you can see that the higher grade component has much larger cells, often more vesicular chromatin, bigger nucleoli, more cytoplasm, and higher mitotic index, as you see there. So we talked about the GFAP positivity. Sometimes I get consults for this reason, and that is that it's, even though we think of oligodendrogliomas as purely glial neoplasms, just like the astrocytomas, it's not that uncommon at all to find some synaptophysin positivity, and in some cases, even extensive synaptophysin positivity, to the point where it's even been noticed that those that have this dot-like pattern of synaptophysin positivity will often correspond to the oligodendrogliomas with 1p and 19q codeletion. So we can see synaptophysin positivity in astrocytic tumors, even more commonly in oligodendroglial tumors, and that does not make me change the diagnosis to a glioneuronal neoplasm. So this is something that was identified in the late 80s and early 90s by Greg Cairncross and his group. And that is that in comparison to the high-grade astrocytomas, the high-grade oligodendrogliomas were much more likely to be responsive to chemotherapy. In this case, PCV, standing for procarbazine, CCNU, and vincristine. And so this is a patient before and after therapy. Now, as you probably know, when Greg teamed up with David Lewis at Mass General, they found that it was specifically those tumors that had loss of 1p and 19q that had a much better prognosis and were more likely to respond to chemotherapy. And this is now true with temozolomide as well. So this really became kind of our first biomarker that we used. In fact, now it has been decided, the older literature mentioned that maybe 80 or 85% of oligodendrogliomas have 1p19q codeletion. In the new WHO, this is a defining feature. So we have to have IDH mutation and 1p and 19q codeletion to call an oligodendroglioma now in 2017. Until recently, well, probably still now, the most common ways of doing this is with FISH analysis or with loss of heterozygosity studies using PCR-based technologies. But there are a number of genomic techniques that people can use, array CGH, for example. At our institution, we're now using next generation sequencing on a number of these cases. In this case, with about 500 genes, we can do an algorithm for copy number. And in this case, we get the whole genome. And you can see there's 1p loss and there's 19q loss, in addition to monosomy 4 and loss of chromosome 9. So we can pick up other copy number alterations all at the same time. So this will probably replace FISH perhaps in the future if we can get the turnaround time a little bit quicker for these kind of studies. So that's kind of, I focused mostly on the morphology-based criteria for gliomas. I'm going to go now a little bit into the new WHO, this concept of integrated diagnoses, in which we include both morphology and some molecular criteria. And as I've already alluded to, the gliomas is one main area where we're doing this quite a bit. The other is embryonal tumors, which I won't have time to go into today. But this is all based on these biomarker concepts. As you know, biomarkers that we use can be diagnostic, prognostic, or predictive, or combinations of these, like 1p and 19q is actually all three. In terms of the WHO classification, because we're in the business of diagnosis, they focused for the integrated diagnosis mainly on diagnostic biomarkers. And because not everybody has molecular techniques available throughout the world, we tried to focus also on ones that had surrogate immunostains as much as possible for making the diagnosis. So I talked already about 1P and 19Q. That was our first biomarker. It's all three of these. It's now part of the definition for oligodendroglioma. The next one that came around and we're using quite frequently is MGMT methylation assays. This MGMT is a DNA repair enzyme, and if you think about it, it mainly repairs the type of damage that's done with alkylating chemotherapy agents like temozolomide, which we give to everybody with glioblastoma. So as you would predict, because those tumors that have inactivated this repair enzyme, they're not as capable of repairing the damage to chemotherapy, and those patients survive longer if they've inactivated this enzyme. The most common mechanism is methylation of the promoter region of this enzyme. And now this has become standard of care for all our glioblastomas. All of our oncologists want to use that. Now this, if you think about it, this is not a diagnostic marker because many tumors throughout the body can also inactivate MGMT with hypermethylation of the promoter region. It is definitely a prognostic marker, and it's potentially a predictive marker because if you had different therapies you were going to use, then it would be a predictive biomarker. Those patients tend to be more responsive to temozolomide therapy. The problem is that because a subset of those without methylation still respond to temozolomide, even when they're not methylated. So this is not part of the integrated diagnosis by WHO. It doesn't mean that we don't use it. We definitely do, but it is not a diagnostic biomarker. The difficulty with this biomarker is that there are many ways of detecting MGMT methylation, and they're not all created equal. There's also nearly 100 CpG islands for MGMT, so which ones are the important ones? What does it mean when some of the CpG islands are methylated and others are not? And there's many questions that have yet to be answered. We do at UCSF Sanger sequencing on bisulfide treated DNA, and we look at 17 CpG islands and simply score it from 0 to 17 based on how many of these are methylated. Much more important is the IDH mutation status, as I alluded to before, and this was a surprise in 2008 that about 10% of glioblastomas have mutations in isocitrate dehydrogenase 1, which is an enzyme involved in the Krebs cycle. And those patients tended to do much better, be younger patients, and they were most often the secondary GBMs that arose from lower grade precursors. When looking at lower grade gliomas, in fact, it was found that this is by far the most common single mutation, both in astrocytomas and oligodendrogliomas of grade 2 and 3. So about % will have these mutations, mostly IDH1, a smaller percentage in IDH2, which is a homologous gene. And by far the most common single mutation is in IDH1, converting arginine to histidine in codon 132. And we now have an immunostain for this, which is an incredibly useful biomarker because for a number of reasons. So one is the setting of, is this a typical gliosis or a low-grade glioma? We often had this difficult type of a scenario in the past. It's not very cellular. There's only rare atypical cells. If it's positive for this mutant protein, that's a neoplasm. There's nothing reactive that will be positive. So it's an incredibly useful diagnostic marker. Excuse me. It's a useful prognostic marker. Those patients do better. At this point, it's not a predictive biomarker because we don't have therapies targeted against this pathway, although people are certainly trying to look for that. Another thing that has been important now in our classification is looking at ways that glioma cells escape senescence. This is true throughout the body, that there are a couple of very common ways that cancers do this. One is overexpressing telomerase and keeping telomeres longer. The other is called alternative lengthening of telomeres. And in gliomas, it turns out they're very highly associated with glioma subtypes. So we knew, for example, that glioblastomas very commonly had telomerase overexpression, but only in the last few years did we figure out the mechanism, and that is that they typically will have a mutation in one of two sites, not in the coding region, but the promoter region of the TERT gene. So TERT promoter mutations. And here's looking at cancers throughout the body. The most common cancer that does this in fact, is the IDH wild type or primary type of glioblastoma. One of the other most common ones is the oligodendroglioma. So ironically, one of the worst and one of the best of the glioma subtypes both use this mechanism. But in the diffuse astrocytomas that are IDH wild type, they in fact use an alternate mechanism, this alternate lengthening of telomeres with mutations of ATRX, which is involved in chromatin maintenance and chromatin remodeling. So here we have another surrogate immunostain that we can use for detecting this. So normally all cells will express ATRX. So this is the normal situation, which is retained expression of ATRX. If there are mutations in ATRX, most cases will have loss of expression, as we see here. And it's very important to look at this internal positive control, endothelial cells, neurons, glial cells, inflammatory cells, etc. So we now know that we have molecular signatures for primary glioblastomas with TERT, lower grade astrocytomas and IDH mutant glioblastomas, typically with ATRX, IDH1, and I didn't mention it, but almost always P53 mutations as well. So these three characterize this group, and the oligodendrogliomas are defined by TERT promoter mutations, IDH mutations, and one P19Q codeletion. So with immunohistochemistry, we can look at most of these, not all of them, but with the adult type astrocytoma, the IDH mutant astrocytoma, if we find it's IDH mutant by immunohistochemistry, P53 overexpressing, and especially loss of ATRX, we don't have to do any molecular studies. That is the IDH mutant type of astrocytoma. There is another subtype that's mainly seen in pediatrics and young adults, and that is the K27M mutant, the histone 3 K27M mutant type of glioma, which are virtually always located in the midline of patients. So these are mostly the pontine gliomas, thalamic gliomas, spinal cord gliomas, a few other locations. But we also have an antibody for this. So in fact, we now have this major group we can identify with IDH mutations, with additional mutations on the astrocytoma side, other alterations on the oligodendroglioma side, IDH wild type glioblastoma, and this diffuse midline glioma that's K27M mutant, which by definition is grade 4. This is a new entity in the WHO. So even if you don't see necrosis and microvascular proliferation, you can still call this grade 4. Now notice I have not put any oligoastrocytomas in here, and that is because there is no molecular signature for oligoastrocytoma. So the vast majority of what previously were called mixed oligoastrocytomas genetically will either be astrocytomas or oligodendrogliomas. So if you do the characterization of these tumors, you virtually never see oligoastrocytomas anymore. And this term is now discouraged if you're using molecular markers. So we've come a long way, I think, with the new WHO, but one of the big questions that still hasn't been answered is what about this grading criteria that we've been using for decades that long preceded these new molecular classifications? And so is it still valid to use these now that we're characterizing things by molecular criteria? And at least a couple of the recent articles, including this one, suggest that at least for IDH mutant cases, it doesn't work so well between grades 2 and grades 3. So essentially the same survival for IDH mutant grade 2 and grade 3 gliomas. So this is a problem hopefully will resolve in the future. But right now, oncologists typically think of grade 3 as high grade and grade 2 as low grade, but at least in these IDH mutant cases, it doesn't work out with our standard grading criteria. Okay, so